Good afternoon. I'm Shenda Tanjak, the registrar at the college.
And I'm Fiona Campbell, the practice advisor at the college. And we have Shelley Martin joining us as well, who's our quality assurance manager. Today we're talking about the elements of the quality assurance programme, which are the assessment, the portfolio and the professional issue self-assessment, the PISA we call it. Possible changes are coming to the programme next year, and your feedback is going to be really, really important. I've already been to Ottawa, Sudbury, Windsor, Kenora, and a big thank you to those physios that turned up and gave me their feedback.
So we're going to be going through this process today, asking you to complete some polls along the way. I'm going to tell you in a minute how that works. Shelley's here because we're going to be asking you also to send comments and questions, and Shelley's going to be collecting those, and we'll be responding to as many as we can live. Otherwise, we're going to be collecting them and providing you with feedback later. Tell us anything you want. Nothing is censored. Any information that you give us will be valuable to us. With respect to the poll, the way that you're going to take part in the poll, you'll see the question appear on the right side of your screen in the slide window. Select your answer and then hit submit at the bottom. Should be pretty simple. If you have any technical difficulties at all, use the Q&A box on the lower left-hand side of the screen to submit your support question, and a support person will get back to you right away to smooth those things out. If you have a question about what we're talking about today, you're going to use the same box to submit your question, and Shelley's going to collect that, and we'll talk about as many as we can get to during the webcast. And I think we're back over to you, Fiona.
So let's start off with a question. Let's try out the poll system. I would like to know who's watching and where you work. So the first question, do you work in a hospital, in private practice, long-term care, or even a retirement home, home care, the community, or an administrator, an employer? We know many employers are starting to join us now, or any other area that I haven't thought about. So could you take a few seconds and start voting? Where do you work?
We know that for some of you, you're sitting in the room with a couple of colleagues. Don't worry about it too much. This doesn't need to be scientific. We just want to get an idea. I think we have close to 200 people who are out there participating in the webinar right now. So this will just give us a sense of the who you are and where you're coming from. And here are the results.
This is great. So I can see, and it's still changing. We've got almost half of the people watching are from hospitals. We've got a good 20% from private practice, from long-term care. We've got some people from home care, and we do have employers. So I'm correct. There are some employers watching, or people in administration, and there's a good few in other areas. Send that in a comment. I would like to see what kind of areas you're working in that we haven't covered.
And by the way, if you have colleagues who couldn't make it today, the webinar will be available as of Monday on our website. So if we manage to make it interesting enough that you would recommend it to colleagues, we'd be really grateful if you'd do that. So we had another question just before we get into the meat of it, just to get a sense of how many people are listening in each site. And you can see the question up there. Just you alone? You're there with a couple of colleagues, half a dozen? You can read that yourself. So if you want to just give us that feedback, that would be terrific. So I hope that one of the senses that you're getting, and this might seem like a fair amount of padding before we get to the meat, and the reason that you're really here is that although it's a webinar, so that means it's us talking at you, as much as humanly possible, we want to hear from you. We're not going to be able to do that so much during this 45-minute space, but your feedback and comments are always welcome, and you will see us explaining to you what we're doing with it if you watch the website going forward. So here are the results of that poll, Fiona.
Okay, so we have over 60%. You're just watching alone. There's about 15%, you're with another one or two people. A few percent as well with more than 5. And then it goes to about, 10, 15%. A good number of people are surrounding you and watching with you on a computer.
Fantastic. I hope you'll have a few minutes to, if you're with colleagues, then I hope you'll have a few minutes after or in the next few days to talk amongst yourselves, because that's often the best way to generate new ideas.
I just wanted to point out we had a couple of organisations with more than 16 watching at the same time. That's
really cool.
We also had a lot of responses through the message box about the types of facilities, rehabilitation facilities, pediatric, private clinics, different identifying certain hospitals and numbers of people in the text boxes as well.
That's really interesting.
Thank you.
So we've got a really nice broad range, which is just what we had hoped for. All right, let's get into the details about what we're here to talk about. So you tuned in because you're interested in knowing what the heck is going on with the quality assurance program, and we're telling you there's a potential for change. Now, before we talk about what that change might look like, I want to bring you all back to my favorite topic, law and order. It's important that you know that the college doesn't independently set the rules about what the quality assurance program must contain. In fact, the college is invented by the Regulated Health Professions Act. We wouldn't exist without it, and it sets out certain criteria that we have to abide by. And so, with respect to the quality assurance process, we have to have a practice assessment component. There needs to be a self-assessment component, and there needs to be continuing professional development. There needs to be the peer assessment. So these are absolute requirements that we can't change. So when we talk about change, it has to still include those things.
So whatever we choose has to meet the legal requirements.
So let's talk about the program that we have now, Fiona.
So there's 3 elements to the quality assurance program. I'm just going to summarize that. Many of you may have been through an assessment, but for those who haven't, there is a peer and practice assessment, and that's been going on for 14 years. This college selects about 5% of the registration base each year. That can be about 400 physiotherapists, goes through quite an in-depth interview with another peer assessor in their practice about the patients they're treating. The peer assessor will look at the practice area, they'll look at their infection control, ask some questions, how you get consent from patients, and there's a lot of questions in there. There's a portfolio that's reviewed. The assessor asks about the continued learning of the physiotherapist. There's a record-keeping audit. Some of your charts are taken and reviewed against the expectations of the standard. And then there's a final component, the chart stimulated recall, that's part of that interview where actual patients from your practice that you have provided assessments and treatments and discharge are included, and standardized questions are asked to the physiotherapist, and you give your oral rationale. The assessor writes a report, and that comes back to one of the committees at the college. The portfolio that's reviewed in the assessment is the second element of the quality assurance program. This is where we declare every year that we've updated it. We've taken some education or some learning that's improving our area of practice, providing better patient care. And the final third element of the program is the PISA, the Professional Issue Self-Assessment. It's really a short quiz. We look at the issues that have come up during the year, from professional conduct, from complaints, or from coming through the assessment, and we produce a quiz. We never look at the results. All we are interested in knowing is that everybody has taken and completed it. The results are for the physios. The physios, if they've identified a gap, they go and look it up, and we trust that that's done. Those are the 3 elements of our current program.
I guess one way we look at the results is that we see if there's answers on one of the PISA questions that are not consistent, if there's a lot of difference between the way people are answering the question, that might trigger us that our communications materials aren't adequate, and we'll go back and see if we can do a better job, make a standard clearer, provide more educational information. But we're not looking at scores. It's not about passing or failing, as you know, because every single one of you has done the PISA. So let's talk a little bit about what's going on right now. As Fiona said, the current system has been in place for 14 years. And just like you need to reflect on the quality of your own practice, we need to reflect on the quality of our own programming. In order to decide whether the program's working and what changes might be required, we needed to do some background research. Some of you may have seen some articles that were published in PT Canada in the last couple of years. Part of that was the research about the effectiveness of the current program. So what we were able to show was that once a person had been peer assessed, if there were changes identified or recommendations made about their practice, if they were assessed for a second time, and some of you I know a third time, we could show that the changes persisted. So that demonstrates that the peer assessment program is an effective way of ensuring quality practice and sustaining it over a long period of time. That was a really key piece of research. Some other research that we engaged in was looking into the best practices in quality assurance programs for regulators and professionals, not just health professions, around the world. And what we learned from that research, you can find it on our website, but basically what we learned is that there are many variations on the quality assurance program theme. There is no single best way to evaluate the quality of care provided by professionals, except to say you can't just use one tool. You need to use a couple of different ways to look at practice. And then the other piece of research that we did that was really interesting and critical was about risks and supports to PT practice in Ontario. And again, you can find that on our website. What we learned is that there are certain characteristics of individuals that make them more prone to get into trouble with the college down the road. What we did not learn was that if you have these characteristics, you're certain to get into trouble. I think we're years away from establishing that connection, but it was nevertheless interesting information. And that was the homework we needed to do before we could talk about how the program might evolve.
So I had the fun part. I've been going out to Ottawa, Sudbury, Kenora, and last week just Windsor. And we went through, the physios were wise, they were thoughtful, Shenda, and they gave me a lot of feedback. We went through a lot of tools. You'll see some of them on your screen.
So these are the tools that are in use elsewhere in the world.
Yeah, from our research we found, and some of them you'll recognise that we're using at the moment. So the portfolio, I've already talked about the portfolio, but the physiotherapists have been telling me that they would like to see the portfolio change a little. It's not helpful in its current format. It's paper-based. We require physios to complete goals for their learning with timelines. And physios were telling me, we're scientists, we don't learn quite that way. We learn in the moment. We see a patient's condition. We go and look it up on the day. We'll ask a peer. There might be something a little bit more helpful than the portfolio in their current format. The self-assessment, interesting, the PISA, if I can shorten it to PISA, was getting physios together to have a conversation about the standards, and that's what they found useful, and they liked it. They knew it was every year they had to do it. They would get together, look at issues where they disagreed, and their learning, they felt, came out of the conversations. Chart reviews, the record-keeping audit, and not that this is a popularity concert, but competition, but this was not one that physios really said demonstrated competency to themselves or to the public. Just going through a chart and doing a record-keeping audit, useful against one of the standards with many other aspects to their practice. Right. Not a chart review per se, but the chart stimulated recall, I'll shorten to CSR, is a method where a patient record is used, and again you talk through a patient intervention. That, the physios were telling me on the whole, was quite a useful way of demonstrating competency. The multi-source feedback, physios were aware that some of their colleagues, mainly the occupational therapists, are using this as a kind of screening tool, looking at their communication skills, looking at team collaboration.
So multi-source feedback is usually a questionnaire filled in by patients and colleagues.
It's quite a number of people that are asked to fill it out about your practice,
Right.
and that is your team members, and patients will be asked to submit that to the college and to get reviewed. Now, physios, again, we're saying it's useful, they understand communication is important, but again, they didn't feel, or they weren't confident that this was a tool that demonstrates their hands-on clinical skills and thoughtful reasoning. So open, but they didn't think the best. Direct observation, mixed reaction, and really they went, as the profession would do, to the practicality and the cost. Direct observation really may not be the best choice for lots of reasons. The recertification exam, how do I put this? Not popular. I didn't find any people saying, yeah, bring that one back to my practice. I'll just move on. I think the secret shopper, okay, I thought the physios would tell me in these areas that what a dreadful idea that would be to send in a secret patient, secret shopper. But I was wrong. The physio, there's a mixed reaction, and they seem to be very open to that idea because it would demonstrate their hands-on skills, their treatments and their assessments. But again, as the practical nature of the profession, when they started to see how it would look, yes, and maybe an adult sports clinic, I could see that happening. Kenora, I hope you're watching, but you laughed. You said there's no such thing as a secret shopper in Kenora. I don't think that is something that the profession feels would be the best assessment. So really it distilled down into the practice assessment at the end of the day. That's what we're doing, and that's what we've done for 14 years. And maybe that was the best tool to show their competency. Sudbury were very clear that it was long, it was repetitive. I even heard this in Windsor. They repeat a lot of patient charts, a lot of interview questions. They would like to see the college look at a mini assessment. They would like to see it used as a stage or a screening tool, which I'm going to hand it over to you now because you were at the working group and can maybe report on that.
The big reveal, right? Before I get there, I wanted to let you know a little bit about the process. So I told you about the research and the background information that we collected. Then Council appointed a working group to talk about the options, and the information collected by Fiona and other people who were out at the outreach sessions and other feedback we've collected over the years after we conducted peer assessments and from assessors, from Quality Assurance Committee members, all was fed forward to that working group. So they looked at all these options, they looked at the research, and they came up with a proposal. I need you to know that this is not a final decision. This is the idea of the working group about what a new program could look like. The Council hasn't considered this yet, so any feedback that you give us in the next week or so will be part of the background information that goes forward to Council as well. Council's going to look at it in December. Now, at that time, if Council thinks there's a good skeleton there, a good framework, we'll officially begin to consult with you about it. There will be another 3-month period while we try to work out more of the details. So right now, starting right now, is your window to identify implementation considerations and concerns, things you like, things you're worried about, so that we can make sure all of them are addressed before a final decision is made. That's a lot of background to say, okay, what are we talking about? So we're talking about keeping the online education activity. It won't be called PISA anymore because it wasn't really a self-assessment. It's really being, well, you assess for yourself how you're doing against the standards, but it's really more of a knowledge or practical application assessment. So we're going to keep that. We're going to do a better and better job of ensuring that it's relevant to your area of practice. The next thing is this assessment process. So we're looking at a mini assessment that would essentially screen out all of you, the vast majority of you who are doing an awesome job. And identify the few people who probably need additional support to bring their practice up to the expectations of their peers. And those people would go forward to a full-on peer assessment, a face-to-face 3 to 4 hour assessment at their practice site. Now, we were a little worried, or I should say the working group was a little worried, that if we used that mini assessment as a tool to identify people who needed the on-site assessment, then if you're in a workplace with others and an assessor comes in, you're going to be marked as someone who has been identified as having problems. In order to protect your privacy, the working group's recommending a random poll of a small percentage of individuals every year, so that your colleagues won't know whether you were randomly selected or whether your peer assessment is a result of a mini assessment. The working group is recommending assessing 20% of all PTs every year, so on a 5-year cycle. They're recommending that we do not double dip. So you won't be selected for assessment until everybody else has also been assessed. So that means we would probably be selecting who would get assessed in the first year of the program based on the last time you were assessed. So if you've never been assessed before, you would likely get that mini assessment in the first year. So that's the concept. The mini assessment would, we think, be on some sort of online video platform, presumably suited to your needs, with somebody who practices in your area. And the last piece of this is the online portfolio. It wouldn't be mandatory, but it would be a tool that we would make available through the portal on the website for you to track your own goals, to track your learning, any other information. And I assume that whatever the mini assessment looked like in the end, because that's the implementation details we're talking about, it would include a conversation about what continuing education you'd undertaken or what goals you'd identified for yourself. So we know you are constantly assessing your own practice, and the way that you keep track of that will be up to you in the future. So let's ask this question. Everybody likes to give us feedback about this. How many times have you been assessed under the practice assessment program? We'll get you to vote on that.
Shen, did you know? No names, but I know there's one individual who's just been selected for the 4th time who shared that with me.
Oh,
you know
I bet
who
she's
you are.
Tickled. We get lots of feedback from people who've been assessed that it's valuable, whether there was any need for change identified or not, the face-to-face interaction. Nobody is not stressed to be selected. Everybody is anxious, and then when it happens, almost everybody really finds it beneficial. And we get lots of feedback from the assessors saying it improves their own private practices or practices as well because the interaction is so valuable. But we hear you that if we are repeatedly assessing the same people, which is the result of a totally random assessment, that's probably not the most valuable use of our resources, or your time is not the best way to protect the public. So just waiting for those. Oh, and here we go.
Okay.
Look at that.
So there's a good 35%, 40% who've never been assessed. So hopefully we've explained the process for you. We've got most 50% have yes once, a good 10, 15%, 12% twice, and we've got a very small handful 3 times. I'm glad it's a small handful 3 times.
Still. Shell?
Yes, I have someone who reported they've been through 3 practice assessments, and she hasn't had any issues. It was time-consuming, but overall good. And her concern is that she's been to courses and conferences where several physios who have been working as long as I have never been assessed.
Yeah, so that is the concern that council shared, that the system that we have now leaves some people without assessment, obviously, for 14 years, and that the best way to protect the public. And part of the quality assurance program's job is to demonstrate to the public that as a self-regulated profession, you are looking out at each other to make sure everybody meets this quality level. So council said, we got to take a look at everybody, and that's why we have this idea of this 5-year cycle.
So the next question we have for you, do you think the assessment has to be completed in person, as we do currently, to be effective? Yes or no? Go ahead.
So we just really want to know from you whether you think this idea of the tele-assessment could be an effective way for a peer assessor to explore your quality and competency. Could you do it in a 1-hour conversation? It all turns on how good the tool is, but I want to hear from you whether you think it's possible. I already know it will be much more convenient for you. I get that you're going to identify problems. Lots of people, for example, in hospitals have firewalls that will prevent video chats while they're at work, for example. By all means, send those comments in, because technical problems we're just going to have to figure out a solution for. But really what we want to know is whether you think, if you can imagine that this could be a useful way to ensure quality.
The way we had this question, though, is we're asking, do you think it has to be
right
in person to be effective? Yes or no? If it's no, then we could look at
excellent. Okay, so
majority no.
3/4 of you think that it's possible to do it remotely. That is very reassuring. Okay, the next question is this idea of how we're going to select you for the mini assessment. So forget about the on-site assessment. This question is just about the mini assessment.
So do you think it makes sense to select people for an assessment based on how long it's been since your last assessment?
So that would mean you would only be assessed once during the 5-year period. If you've never been assessed, we'd be getting you out the gate. And then at the end of 5 years, you would come up for assessment again. Now, after the program had been in place for 5 years, and I should tell you that council will also be looking at a 6-year cycle. That will be part of the proposal that goes to them just in terms of financial management, because our goal is to maintain the costs of the program. We're not talking about inventing something that's going to drive your fees up. So to the extent that any of you out there were worried about that, council's committed to not letting that happen. So it could be a 6-year cycle, and that might be the reason for it. Shelley, does anybody have any feedback on this point yet?
On the cycle, no, there's lots, I have lots to choose from for general comments about the process itself. Not the timelines, though. We do have someone asking about what percentage of PTs would be included in a random pull.
So we don't know that yet. That's a super good question. Yeah. The smallest possible percent to ensure privacy. So I'm thinking if we're looking at assessing 20% a year, maybe 2 or 3% would be subject to the random pull, okay. but that remains to be determined. So look at this. 89% of you think that it's a good idea to do it by time.
I do have 2 comments that have come in on the time frame. Someone stated, I feel that 5 years is too short a time, and someone else has stated, I think every 5 years is too often for an assessment. Yeah. Once every 10 years seems more reasonable.
So I think that we are receptive to that feedback. What we need to do, what the research showed, and Fiona was one of the co-authors on the paper, so she's better positioned to speak to it than I, but I promise I read it. The research showed 6 years of sustainability, right?
6 to 7. We were seeing a sustainability, yeah.
So I think we need more data to demonstrate that 10 years would also be adequate. But I think that we'll continue to collect that data. So after the first 5-year cycle, we would be reviewing how it was working, and it might be extended in future, I think. Next question.
That was very conclusive, though. People were open to that. Do you think it makes sense to use a mini tele-assessment to identify people who need a full in-person assessment? Yes or no?
So
That's online.
the mini assessment is going to be used essentially as a screening tool, and the contents of that assessment must look quite different than the on-site assessment today. So part of the giant job associated with changing the program will be coming up with the right tool for the mini assessment, but the idea is to develop a tool that will be an effective identifier for people whose practice may be at risk. So that's the role of the mini assessment, and that's the question that we're asking you is, does that sound like a sensible way to approach the on-site peer assessment practice? Look at that.
I think yes, that's quite conclusive there, Shenda. It's almost 96% have said yes, and 4% have said no.
This is so important, this feedback. It really is going to demonstrate to the working group that they're on the right track. You know how it is when you sit in a room with colleagues and you come up with a plan and you think it's a great plan, but you don't actually know if you just sort of got into the moment and lost track, and you need to do a reality check. You guys are being our reality check right now, so this is terrific.
And it's so exciting because I wasn't at the working group, but I've been on outreach, and I know the physios. They're thoughtful, they're wise, and they're coming up with very similar things to the working group.
So that's great. The next question is whether you think it makes sense to only do the on-site assessment if problems have been identified. So about half of you have experienced the on-site assessment, and I think Fiona has done a great job of describing it. It's the 3 to 4 hour long in-person conversation with chart reviews and chart-stimulated recall. I like the chart-stimulated recall, for those of you who haven't done it, is intended to sort of probe your clinical reasoning. So I think it's a critical component of an assessment.
I mean, the gold standard would be watching you with a patient, but the next step down, I think, is to have a chart that records what you did, and for you to be able to talk to what you did and why you did it.
Right. So the idea is we would save that level of assessment and engagement only once you'd been identified as at risk, and almost all of you think that's a good idea.
Yes, that would be 99.3%
That's
have
amazing.
said yes.
So I don't know who you are. There must be a couple or three of you who don't think it's a good idea. Please make sure that you provide the feedback either right now or later, so that we know what your concerns about it are, because this is, I think already Fiona said, it's not a popularity contest. We really do want to hear whether you support or oppose the proposal, but we also need to hear from you, even if you're a small percentage, to make sure that you haven't identified a fatal flaw. So this is a more general question about what else we should do to support. It says ongoing learning, but it really means continuing competence in the profession over your lifetime. What can the college do as a regulator? One thing we can't do is provide educational courses for you. We're not really in that business, although we sometimes see the need and sometimes get the request, but we do want to hear from you about this. Maybe I'll turn it over to Shelley to identify any questions or comments.
Okay, sure. We do have a comment. I would like to see a minimum standard of education for controlled acts better outlined. Is a one-day course enough?
That's a good question. Council deals with this one from time to time. As you know, especially if you have ever put yourself on the roster, we don't specify the duration of a course. We trust that you are the best person to evaluate whether you've had enough education to undertake one of these dangerous acts. At this time, there is no conclusive evidence that a one-week course or a one-year course is a better protector of patient safety than a one-day course. But this is something that we're always watching. When the evidence demonstrates that patients are at risk because of the performance of a particular controlled act, we'll have to re-look at what it takes to get on the roster.
We've not seen those red flags yet, but if you were to phone in and call about the education, we've got lots of calls about this. People were taking, I think it was acupuncture courses. They were taking a day, but when I asked, the standard said there should be a theory component, a practical component, and an evaluation component. Where in the course is there an evaluation? Evaluation can look very different. That was the sticking point. They would go back to the providers and ask for an evaluation component.
And so maybe that's a piece of this that we can take forward, is to build that up a little bit more in the communications materials. When you're asking yourself whether your coursework was enough, what we really mean by that evaluation component. And of course, you can send the course leaders or the instructors or the programmers to us to ask what we require, and we can explain to them what we mean by evaluation.
Here's an interesting question. Good afternoon. I've been selected for a practice assessment and have been scheduled for early February. Do these new changes affect me, as this would affect my preparation for my upcoming assessment? Would my current assessment be postponed?
Sorry, no.
Nice try.
If you've been selected, you should prepare. I should talk a little bit about timing, or maybe Fiona, you can explain what the next steps are.
So my understanding at the moment is that we've got this proposed programme that Shenda went over on the slide with you. That will go in front of the council, our decision makers for the profession, and they will review it. If they decide it's ready and they would like it to go out for broader consultation, that will happen between December and March. And if we'll gather the feedback and look at if there's any modifications, revisions, changes to be made. If it's going smoothly, it'll go to the March meeting for a final decision. If they approve it, it will be final and implemented. And then, as you've already said, there is a lot of work to be done based on some of the feedback physios have given. You've said about the privacy, the confidentiality, the practicality of implementing that research will have to take, I would suggest, over a year before we can even look at implementing.
So Shelley is the manager of the quality assurance process, and she's responsible for ensuring the selection for assessments and stuff. So Shelley, if council decided to go forward with this proposal, which would mean ending the current program, when would the last assessment take place, do you think?
Likely before the end of June. We do random assessments every month, and we've set a target for this year, which means selecting every month until including March. And once you're selected, there's a 3-month window. So anyone who's selected in January, February, March should be through the process by the end of June.
Right.
So I suspect everything will be wrapped up.
Right. And it will be council's decision whether to continue with the current process until the new process is ready. But basically, if you are selected, you will be peer assessed, because we'll stop selecting at some point, and we'll of course let you know.
So Shenda, if there are revisions to be made to the proposed programme, can you see everything shifting then to a different council meeting? Or are you still targeting?
Of course. So the feedback that we've got today suggests we're on the right track, so there's no good reason to think there's going to be a tremendous delay. But in the effort to get it right, council will revisit this issue as many times as is required until they've got a program they're happy with. So I'm hopeful they'll make a final decision no later than March. But they want to get it right. We'll just keep on doing more research and bringing more information back to them, and it will take as long as it takes. The current program will continue. We know it's effective. I mean, one of the things that's amazing about this opportunity is we have evidence to demonstrate our current program is good. We got your feedback that it could be better. You don't want to be reassessed and reassessed, and we hear that, and there are other things we think we could do to improve it. But we're starting from a really good place. Back over to you, Shelley.
My gosh, thank you for sending in all these questions and comments. I don't even know where to begin. Someone asked a question: how will business practices be assessed in the mini assessment?
That's some of the work over a year we'll have to look at. I mean, it is an issue, and we have to put it on the table. There are issues around billing fraud, and I think somehow we're going to have to look at that more thoroughly in the new assessment. That's an idea. How we need to do a lot of thought about that.
Yeah, we haven't begun those conversations, but if you have ideas, send them in. What we know is that the tool needs to be different depending on your practice setting. So most of you, or half of you today, are watching from a hospital. What your business practice requirements, your fees and billing requirements look like is quite different than somebody who's in private practice or long-term care. So we need to have different tools for different settings, and that means the more information you give us about how you would go about assessing the practices of your peers, the more we'll have to build a good tool on.
Can I just plug that there will be an online survey, so if you're sitting there thinking, I've got an idea, please include that in the online survey that will come out to you at the end of this webinar.
We have a few comments about suggesting mandatory hours for continuing education or continuing education credits. So a couple people have asked about that and commented on that.
Now, I think that the research paper about best practices around the world that we did, that Dr. Zubin Austin conducted for us, demonstrated that there's no evidence that a required number of practice hours yields better patient protection than other sorts of requirements. So the practices vary around the world by profession, and even within health professions and across PT colleges across the country. So we're not talking about mandatory PT hours or CPD hours because there's not evidence to show that that's going to be helpful. Again, we leave it up to you to figure out what you need and when you'll get it.
And I can certainly say, speaking to a lot of physios, I had people with years and years of experience in one area, and they told me they might sit down once a year to look at the best practice and do a review of literature. Newer grads are saying, whoa, I'm taking courses, I'm doing way more than that. And I think that's okay, based on your experience, your practice area, what you need, what your gaps are.
Well, and what we do know is that, well, what we know from our risk research is that people who change practice settings frequently that's one area of high risk. What I take from that is you don't have a solid colleague cohort to talk to. One of the most effective continuing professional development mechanisms is those hallway conversations that you have where you're bouncing ideas about patient treatment off each other. So people are bad at assessing their educational needs. There's tons of evidence about that. So I could sit here and say, all right, I need to take an acupuncture course, when in fact that's because I like that. I'm good at it. It will be easy and painless for me to take the course, and I'll do it with my friends. So it's not really having an impact, but I could toggle some hours. Whereas the conversation I have in the hallway with somebody who is been trying a new technique with patients with a particular problem is more likely to yield benefit to the patient. That's where the learning's really going to come from. Shelley, what else have you got?
We have an interesting question. Someone asks, what about doing assessments or evaluations like they do on paper in Quebec? Can you comment on that?
Sure, I guess it has to be me or you, Shelley, because we were both at the Quality Assurance Working Group meeting. You should know that Shelley, by virtue of her position and her expertise as staff at the college, was a contributor, so she could bring the practical element and the feedback from peer assessors into the conversation. The working group did look at the tool from Quebec, which is essentially, for those of you who don't know, at the annual renewal time, you know that presently we ask you some demographic information. Quebec has built something out bigger that if you identified in answering those demographic questions, if there were things that identified you as higher risk, you would be given automatically more questions, so that you would end up filling out something that looked like a relatively in-depth practice profile. And that would be the risk screen that would take you to the next step, which might be a peer assessment. Shelley, can you talk, I'm putting you on the spot here, about why the group thought the mini assessment might be a preferable tool?
The time frame in the mini assessment would do a larger group of physiotherapists to ensure that we were looking at everyone across practice versus targeting certain groups or appearing to target certain groups. And then it would ensure to the public, it would look very reassuring that all physiotherapists were equally likely to participate in the program, and then there would be a set schedule.
Yeah. I think the other thing that we know from practical experience is that sometimes the most troubling practitioners that we encounter don't have all of the highest risk indicators. And that might be for a variety of reasons, including health. So it could be that you're stressed or you're mentally ill or you have an addiction. And I hope you know from reading the college materials that we have supports and can help you with that if that comes up in your practice. That would be unlikely to be identified in a practice risk profile screen, but maybe one of the most frightening conditions from a patient perspective. So it felt a little bit more comprehensive to hit everybody once through, I think.
Okay, are you ready for another question?
Do it.
Someone asks, will this save money and positively impact fees?
No. I say that with a caveat, though. It won't cost more money. That's the mandate and the exploration that Council has asked us to undertake. The question about fees and what the program ultimately costs, we're a long way from making that decision. Although I think I can promise you on behalf of Council that your fees won't go up. I'm telling you, watch this space.
Okay, someone had a suggestion. How about selection by practice setting? Hospitals have their own performance reviews, usually done annually.
Yeah. Gosh, I'd really like to do that. I know that some of you work in settings where you have a ton of support and employment good performance evaluations, but you'll remember that slide about the law. So we're required to undertake these elements of the program. I am hopeful that one day we'll be able to work with you in your employment setting to develop a partnership so that it's happening in one place or the other or not both places. But right now, our obligation is to look at all those three pieces.
Can I just plug though, I would love to hear what they're doing. I mean, even if they send that in to us and we have that information and you have it at your disposal to consider perhaps in the future.
I think that would be really helpful, yeah.
This is interesting. The college does not maintain a category for active practice for those of us who do not do patient care. Yeah. How are those people affected by these proposals?
So I think that that's an interesting and specific question that the working group is going to have to continue to work on. Mm-hmm. Certainly, if you are not in active practice, it doesn't make much sense to use the same tool. Does it make sense to assess you at all? I think that's part of the implementation details. I think what I've noticed from my work with other regulators across the country is a problem about those who wish to return to practice, those who work in an administrative capacity today and 5 or 10 years from now wish to return to practice. If there's never been any assessment in the interim, it can be really complicated for you to return. So what we need to do is figure out a way to assess you that makes sense with respect to what you're doing today, I think.
Okay. Let's see. We've actually had a few questions about regulating clinics within this stream of thought, because a couple of them commented on pharmacy clinics are regulated and assessed.
Yeah.
So Any?
Yeah, it's so some of you might be familiar with the work that our college led advocating for clinic regulation over the last couple of years, which culminated earlier this week in submissions to the, again, my law geek hat is on, the standing committee that's contemplating legislation right now about clinic regulation for medical clinics. So the college president, Gary Rian, and I were there in the ledge asking them to consider including clinics where things that aren't medical take place, because those require patient protection as well. So I think we've tried. Some colleges can look at places, pharmacy for example, because the legislation requires pharmacists to own the clinics or be in charge of the clinics, so they have a way of getting in that our college isn't empowered to do.
Okay. Someone else wants to know if any other colleges are using mini assessments leading to bigger assessments.
Yeah, no, this would be another example of how Ontario physiotherapists are cutting edge. Don't you think, Shelley?
Yeah, I think so. I think there are colleges using some screening tools. I think they're experimenting. I believe the pharmacists are or one of the colleges doing interviews or trying out interviews, but I don't know if they're considered mini assessments or if it's looking at their continuing professional development. So I think we'll be within a group of a few regulators that are already doing this. Or looking at doing this.
Looking at doing it, yeah.
Yeah. Okay. Someone here just chiming in from a teaching hospital. While performance appraisals are expected to be done every 2 years, it doesn't always happen at the frequency it should, and often not by someone who can speak to the professional practice. That's a good comment.
You know, we did a survey at the college, and we did find that some people hadn't had any review on their clinical performance for 15 plus years, yeah. and it was they wanted it. I know when I've been on outreach as well, people are quite open to more input, be it an assessment, be it an assurance of competency, but it's still feedback that they would like.
So I think there's some tension, of course, because it's scary when the regulator big brother comes and sticks our nose in your business. And I want to ask you for what's maybe impossible. I want you to trust us. I want you to provide feedback to tell us how that 1 hour that we propose to have with you once every 5 years can be most useful to you. So I'm going to take from that teaching hospital comment that as an administrator or a senior professional or an experienced person in a teaching hospital, you want some look at the clinical competence of the people that you work with and maybe yourself too. But this is the kind of feedback that we really need from you. What can we put into that 1 hour that's going to help you know you can be the best that you can be, and reassure you that the people that you're working with, whose patients you're going to inherit or who are going to form the public perception of your profession's reputation, what can we do to make sure everybody is as good as you want to be?
Okay. We have a comment. Someone's commented the in-person assessment is effective only when a direct patient interview or observation is done. That's just a comment, someone's feedback. And a few people wanted to know, and they've worded this in different ways, that if you are on a roster, will you have to do the mini assessment more frequently than other physiotherapists?
That wasn't part of the working group's recommendation, so I think we're ready to move on from that. Our experience over, when did the roster come in, Shelley?
2012, I think.
Yeah, so we've got solid 5 years, and we are not finding evidence that those of you who are rostered have more problems in practice than those of you who aren't. So I think we can start treating you the same.
Okay. We had another comment about concerns about privacy at work, and this PT stated that they would not feel comfortable talking about their work profile for the mini assessment at work while others could listen in here, but they'd be happy to do it at home.
Fantastic.
Participate at home.
So that's the kind of, we'll be collecting and collating this information, and some of it sort of falls into the category of the big picture program decision making, and then some of it falls into the category of implementation. So if we can protect your privacy, we can go forward with this plan, is sort of what I'm hearing from that, and that will be a primary factor in the implementation considerations. And I know you all want to spend your spare time doing this.
Okay, so...
Oh, and in case you were wondering, yes, you can still volunteer for an assessment.
And we have someone commenting, do you have PTs on the working group from each of the major practice settings, i.e. home care, clinic, hospital settings?
No. So what we have on the working group are people from council and experts in quality assurance. We're counting on you through this process to give us the feedback from the particular sectors. Let's talk about how you can give us feedback. So I will be blogging about this the next week or two. This is such a key place for you to provide feedback, because you can read what your peers say. So it can be a conversation amongst yourselves. Maybe you know, maybe you don't know the rules of our blog. You can say whatever you want. Sometimes you are so mean, we don't take that stuff down. It stays up there. If you breach somebody else's privacy, or if you use really offensive language, we'll take it down. But otherwise, it's absolutely an anonymous platform for you to give real feedback to the college and then to each other based on the comments. So feel free to go to the blog, because there's no word limit. You can say whatever you need to. We'll also, you're always welcome to email us or to provide feedback through Twitter or through the Facebook page. You can call the practice assessors. We can move on to that slide so that you can remember who they are. It's not actually the best. I need my practice advisors to have time to give you advice. Fiona's going to talk about that in just 1 second, but you certainly can call them. And there's going to be lots of formal opportunities, including a survey that's going to go out to all of you who are participating today at the end of the webinar. But there will be lots of formal opportunities for you to participate through our website. And of course, anytime you want to write or email to me, you should do that, and I will make sure the information is fed forward. We're accountable to you, and I think sometimes you lose track of that. If you look at the council materials, they're all available online, and you will see how we have collected the information and fed it back to council. So what you tell us goes forward to them. Not word for word, that would be too many pages, but you will see the information summarized.
I just think an online survey at the end, and it would be awesome if you could take that survey and just distribute it to your colleagues, peers, other people that you know. The more feedback, as Shenda said, the better, to get it in for you. So I know that we only have a couple of minutes left, so can I just have a little plug? A little plug for the Practice Advisory Service. We're trying really hard. The 3 people on the screen, we want to provide a live call answering service to you. We know between 8:30 and 5 we've structured it so somebody is sitting right at the phone to talk you through any questions, any dilemma. If we don't know the answer, we'll try and look it up, as long as it's related to practice and the care of patients. But that's us up there. Our number, we have a direct line, 647-484-8800, and we hope you'll use that service.
And also tell your patients or their caregivers to call our practice advisors, because if you know that your loved one has a question about what to expect from a physiotherapist or the office, or was this really what should have happened, the practice advisors talk to lots of patients, and that's part of their role too, and that can get you off the hook sometimes. So feel free to send your patients to them as well.
And employers. I know we had some online, but employers, other stakeholders, insurance companies, all welcome to call us, and we will try our best to get the best answer. I do want to plug as well the standards. We've just got 1 minute left. Since 2016, the Council has been working really, really hard. There's 11 new standards. I've got the feedback. People are finding they are shorter. That's deliberate. They're concise. They're rule-based. We hope you understand them better than perhaps previously, but our role as practice advisors is to know those standards and to help you work through them. But have a look, make sure you're aware of them. And we had a slide at the beginning that lists the new standards that are out there for your practice.
So thank you. I think there's more coming in every minute, but we don't have any more time. So we're delighted, we're thrilled that you came to see us today. Share the webinar with your colleagues and your friends. Make sure as many people have these conversations as possible, and keep watching our website to see what's going on next. Thank you.